Welcome to The Cut, a series where I'm talking to experts about how small changes can have a big impact on patient outcomes after surgery. Dale, thanks for joining us today. It's great to have you share your stories in your clinical experience. So tell me, surgical patients, they've had a massive trauma, or you've created that injury to the skin. What's really important in terms of post-operative rehabilitation from a physiotherapist point of view?
Thanks very much for the opportunity to chat today, Kylie. It's fantastic to talk with you and your group. I think the main thing for me is that we want to get patients moving early. We know that it's not necessarily about the skin and the skin healing in terms of the patient's long-term rehab, certainly a part of it, but our big issue is the loss of muscle, which comes with patients being stuck in bed. And clearly, if they've got an incision, a wound, then they're going to be very reticent to get up and about due to pain and other issues. But they're also very fearful of the fact that they've got this wound and they don't want to make it worse. And, we as physios have to come in and try and get around that issue and get patients moving as early as possible, because even one day in bed, patients are losing anywhere between 1.5% and 5% of their muscle power a day. So every day in bed makes a difference, and we need to manage all of those different domains, including the skin healing, to allow the patient to get the best outcomes that they can possibly get, and also get out of the hospital as fast as they possibly can.
Yeah, and you find these days that patients are being discharged far more rapidly than perhaps they should be?
Yeah, look, that's a double-edged sword. The system is set up such that now we have to get people out of the system. The most expensive part of the system is the hospital, obviously, and the longer people are in the hospital system in a bed, then they're going to their health costs soar. They go up a lot, significantly, particularly during their acute stay. So the system is geared, obviously, to get people home as fast as possible, and obviously I'm geared. My profession are geared to get people moving as much as possible. That isn't as much a concern for me as getting people out of the hospital. It's more about making sure that their long-term loss of muscle and condition is minimised during their hospital stay. And usually the two come together anyway. People get out of the hospital faster if we can get them out of bed faster. And our research has demonstrated that in the burns cohort. If we can get patients up within 2 days of their surgery, then that's associated with an earlier going home date. And so that's not all about, obviously, healing, because people heal when they're at home, but certainly getting them out of their acute hospital stay, we need to certainly focus on getting them moving, getting them managing their wounds, and being confident and comfortable enough to do that. And the dressing systems also help in that space.
Yeah, tell me more about dressings in particular, and a lot of our viewers, they want that miracle dressing that just does everything. What is it that you think, from a physiotherapy perspective, the characteristics that you look for if you need to change a dressing that's going to help the patients, particularly because they've gone home, haven't they?
Yeah, look, I know that this grey hair suggests that I'm very young, but I think about dressing systems as part of the system, obviously, and I'm a systems thinker. And so I've spent 20-some years working with the nursing staff and the medical staff to actually look at the best dressing systems to allow patients to get moving early, and to allow patients to get moving fully, and to maintain the best function they can while they've got those dressings in place. So the best dressing system is low profile. It means that it doesn't block people from actually moving their joints, and obviously that's a big issue around the hand. The best dressing system also maintains an interface with the wound that reduces pain through whatever mechanism it does that, reducing drying out, reducing air contact, maintaining that nice moist interface. And I guess the other aspect of the best dressing is that it isn't the best dressing, it's the best dressing system. The system is customized to the patient's requirements in terms of where their location of injury is, and also how that system is going to stay in place and protect the wound and give the patient the best outcome, give the patient the best pain and analgesia, based on the fact that it still needs to be affixed to the body. So not everything can be affixed with sticky tape or sticky cloth tape. It has to be affixed in other ways in some circumstances. And so the dressing system is a much more holistic approach to maintaining the best wound healing environment.
That's a really great way of looking at it, Dale, because if you think of the macro to the micro, you have that multidisciplinary team approach when you're managing that patient. And then when you look at the micro, it's a system. The dressing is part of that sort of the cog, one of the cogs in the system that helps improve that patient's recovery. But do you find that, particularly with rehabilitation, do you think it's a great idea to be able to see the wound or the incision? Or do you think from the patient's perspective, they're not that keen to see their wound?
I guess to me, some of that relates to where the wound is. If the wound's on your face, then probably most people would not like to see that wound, because that cosmetic and aesthetic aspect of them rediscovering themselves after they've gone through surgery can be influenced and can be potentially influenced negatively. So I think it's not a bad thing to have that wound covered up and the patient not necessarily being aware of it until it's in a much more healed state. So that's the other thing that I think is a challenge for patients in terms of the scarring of the mind, is that, is there benefit in them seeing themselves damaged? What is under the wound dressing, versus them seeing themselves after the wound's healed, essentially. And, yes, there's a scarring process and change will continue to occur. But during that acute period, I think the jury's out as to what's the best. Certainly, I think we need to be able to monitor the wound in terms of negative outcomes, or in terms of adverse events such as a bleed or some form of negative event like that. So we need to have enough visualization. Sorry, that's a big word that I stumble over. To allow us to monitor the wound well when we're moving, when I get patients up and about. But then by the same token, we obviously don't need to show the wound to everyone, including the patient, as a general rule. So I think opaque dressings are fine as a general rule, but obviously having a way of that dressing to show strike through or to show bleeding is of great benefit as well.
Yeah, I think that's one of the great things about early visualisation, is you can pick up on a complication quite early on if you can see what's happening at the wound interface. But some patients may not be too keen to do that.
No, for sure. And I think, really we need to clinically monitor the wound at all times, or be able to. And, and I guess what I see as a good dressing system is that the fluid actually changes the colour of the dressing, and that at least alerts you to something going on, so whether there's an excessive exudate or whether there's a bleed or, some other form of serous ooze, whatever it is, for that to be an indicator of a complication or a potential adverse event, we want to address that as early as we possibly can. And if the dressing can alert us to that, that's a great dressing.
It'd be pretty neat if dressings did do that. It'd be really great.
Yeah, we've been working a bit in that space, looking at integrating bioimpedance and other electronic or electrical assessments with dressings, and I think there's some exciting times to come in that space.
I think so too. There's a lot of work also around sort of temperature measurement, dressings measuring wound temperature, which is really can be an indicator or not of a complication. So I think I agree. There's lots of interesting things happening in that space. So it's an exciting time to be a part of that. That bioinformatics or biometric dressings.
Yep. And that doesn't need to be as complicated as it sounds. It can be just a colour change indicator, which is actually just a chemical reaction associated with what's actually being released from the wound, or, as you say, the temperature, or whether there's a change in the electrical conductivity or charge of the wound surface. All of those things can be used as indicators, and they don't have to necessarily have a high fidelity wound system management and monitoring system. Obviously, there are some things in that space, but certainly we can go a long way with just having an indicator built into the dressing. And I think that we're not far away from that being a much more broader application within the dressing systems that we're seeing now.
Indeed. Wouldn't it be great if the dressing could talk to you and say, I need changing?
Exactly.
Thank you so much for your time today, Dale. It's been great to chat with you, and looking forward to bringing you back for further episodes of our series.
Thanks so much,
Thank
Kylie.
you.